I just tell in Bangla that this is like, she's like Ratna Garba. So we really honor her, and we actually want to tell you that you should be proud of your mother, and we all pray for the departed soul. And then I'm thankful to see that my junior colleague from Dhaka Medical College from Shandani years, Shandani was a voluntary organization of medical students of Bangladesh, Professor Dipal Adhikari from Bangabandhu Sheikh Mujib Medical University. And then I see Saidur, now professor of cardiology and actually I would say heavy-handed interventionalist in Bangladesh. Saidur and I go back since I started the interventional work in Ibrahim Cardiac Centers since 2005, right, Saidur? Long time. So it is nice that you were able to join us. Then I see Professor Azam. He is probably the charming cardiologist of Bangladesh. Where is Azam? I saw him earlier. And it is a really privilege and honor that lately I'm able to work with him closely, and I welcome him as well. I'm just looking at Nasir. Do you see anyone else?
We have Dr. Malik. Dr. Malik from CMH.
CMH, thank you, sir, that you joining us. And I will make this presentation like didactic, and will ask the participants, and also I'll ask the faculty to jump in. Also, I want to thank especially the chairman of the Planetary Health Academia, my junior friend from Dhaka Medical College also. He is very well known in Bangladesh for his work and involvement in COVID-19 pandemic, Professor Tasbirul Islam. And last but not the least, my dear friend Nasir, he's taking all the troubles to bug people, bring people, and get people together to make it a success. And we are here all for a noble cause of promoting education and our collective experience. And I also wanted to take this opportunity to thank actually the participants, because this is successful because you came.
Thank you, Hafiz Bhai. I would like to, we have Dr. Kamrul Islam also present here. Thank you for joining us. We are honored to have you. I would like to have an introduction to Dr. Chowdhury Ahsan Hafiz. Everybody knows Hafiz Bhai, but for the juniors among the participants, I would like to tell you a little bit about Hafiz Bhai before we start. Professor Chowdhury Ahsan Hafiz received his medical degree from Dhaka Medical College and awarded the gold medal in medicine. He then received the Commonwealth Scholarship and completed a PhD in clinical pharmacology and medicine at University of Southampton in United Kingdom. Then he moved to United States, and he did his postgraduate training in internal medicine and cardiovascular disease at the University of Pennsylvania and Drexel University College of Medicine in Philadelphia. And he did his interventional fellowship in Mount Sinai Medical Center in New York. He's board certified in internal medicine, cardiovascular medicine, nuclear cardiology, interventional cardiology. He was awarded the Young Investigator Award by American Society of Nuclear Cardiology in 2001 and American Society of Echocardiography in 2004. He was the associate professor and the director of cardiac cath lab at the University of California Irvine Medical Center before he joined Nevada Heart and Vascular Center. And Dr. Ahsan is the director of cardiology fellowship program at the University of Nevada in Las Vegas. And Dr. Chowdhury started his volunteer work in Shandani as a medical student. He continued to contribute to the education and promotion of cardiology in Bangladesh. He has done a lot of work over there. And we are really delighted to have Dr. Chowdhury Ahsan as our speaker today. Hafiz Bhai.
Thank you. That was a long introduction, but I'm a little embarrassed. Dhiman, Dhiman from National Heart Foundation just texted me that his uncle got sick in critical care in Asghar Ali Hospital in ICU. We pray for the speedy recovery. he has apologized. He could not join us. Well, let me go through these key concepts. I think it is important that we highlight this for our participants, and then we'll go to the topic for the day, which is the ST elevation MI. It is important to recognize that with all these biomarkers now available and a lot of confusion around, we just want to make sure that we do understand what we call myocardial infarction. It is the hypoxic tissue injury, hypoxic myocardial injury, that gives rise to the rise of biomarkers. We call that MI, and therefore a patient with fever and inflammation and getting this injury to the myocardium and troponin rise is not MI. But if we consider the hypoxia related tissue injury and the elevation of the MI, we'll have to think about how that happens. And this has important therapeutic implications, and therefore it is important to understand the underlying pathophysiologic mechanism, the types of MI, and then how we can recognize that with the EKG and the clinical history. ST elevation MI, I say this all the time, it has two parts, ST elevation. So we need to recognize the pattern of ST elevation, and we need to recognize that this is MI. There are other causes of ST elevation, and if we don't recognize this clinical picture, we may end up with disasters, and that will not be a good thing. So the atherosclerotic pathogenesis in the arterial wall, we read this in medical school, that there is the LDL oxidation, this inside uptake of the oxidized LDL, there is this inflammatory cells, plaque formation, and then macrophage comes in, the lymphocytes, and then the fibrous tissues formation, and then plaque ultimately grows. There is neovascularization, and when this soft plaque with the fibrous cap, thin fibrous cap, thin fibrous atheroma, and there is a plaque rupture, plaque erosion, and there is occlusion of the vessel or near occlusion of the vessel, then we call that hypoxia-related tissue injury as type 1 MI. This is very, very important to understand. On the other hand, in type 2 MI, there is a mismatch of demand supply, and there is hypoxia. It could be carbon monoxide poisoning, or it could be severe anemia, it could be sepsis and hemodynamic embarrassment, and there is hypoxic hypoperfusion and tissue injury and the troponin elevation. That could be type 2. Type 3 is the recognition of the sudden cardiac death, and we don't really need to worry about that because that's we don't deal with. Type 4 is post-PCI. For this audience, I think type 4 or type 5 we can also ignore. But it is important, very important to recognize that the type 1 and type 2 MI we recognize. Little confusion here that spontaneous coronary dissection in the young, or there is aortic dissection related coronary. These are also, or Takasubu, for example, without any significant issue with the atherosclerotic pathogenesis in the arterial wall, is also labeled in type 2. It may be a little confusing, but that's where we are. So this is a long history. WHO and the European Heart Association, Cardiac Society, and the SEC, they have gone through this, and they have labeled this ST elevation, MI, and also the different types. When we call the ST elevation, there is this, we all are familiar with this, that from the J point you see these ST elevations, and there is little variation in the male and female, but generally speaking, for day-to-day purposes, 1 millimeter ST elevation or 2 millimeter in the precordial is good enough. And then reciprocal changes can be there, but it is not a must, and we'll follow that when we show the examples. So one more time, that type 1 MI, it can be due to the plaque rupture, plaque erosion, and two things happen. There is activation of the coagulation cascade, and there is activation of the platelets when there is this underlying plaque that becomes unstable or shows further progression with plaque erosion, plaque rupture, and then discontinuation of the endothelium, perturbation of the endothelium, and activation of the coagulation cascade and the platelet activation, key pathogenesis in the subsequent clinical events of myocardial infarction. Therefore, all our therapy should be focused on how we can get rid of this thrombosis, and then at the same time, it is a mechanical complication of the atherosclerotic plaque, how we can pacify and make sure that we do intervention so there is no recurrence of that event. But that begs the question that for the future for the patient, we need to address the underlying pathogenesis and therefore address the modifiable risk factors as much as we can. So this is a variety of issues that can happen. And in COVID time, it is very important to recognize this. Otherwise, we pose risk to the patient and to the healthcare professionals for doing unnecessary procedures and exposure, and also management issues, because some of this could be inflammatory or cytokine surge related LV systolic dysfunction, completely fooling us that this could be coronary atherosclerotic related changes. So this is very important. I want to make sure that we understand the troponin. The troponin now is the 5th generation. This could be confusing. You need to pay attention to the units that is expressed in the current era, that it can be nanogram per liter, or it can be in picogram, whatever it is. The absolute value of troponin also has some meaning, and I'll come to that in a second. This is a big list. I already went through that. The type 2 MI is a mixed bag. So if you do not have the clinical conundrum of chest pain and the symptoms, and then EKG, and then wall motion abnormality, then if you do unnecessary procedure, you may end up in disasters. What is the value of the absolute troponin? If you look at this picture, then at very high level, the differential of troponin elevation becomes very small, very, very limited. Large MI, myocarditis, stress cardiomyopathy, only few. But when you are looking at small troponin, I call it mini troponin, your differential is even more. So therefore, when there is a very high troponin and there is a typical rise and fall, that goes more in types in terms of accepting that this is probably type 1 MI, and the treatment for type 2 MI, for example, if it is anemia and troponin, you don't want to give blood transfusion and heparin. That is not a very smart move, and actually you will be doing harm. On the other hand, if the troponin is elevated, and it is indeed the underlying pathophysiologic mechanism and the clinical evidence is suggestive of type 1 MI, then everything we need to do is targeting this antiplatelet and institutional anticoagulation and mechanical revascularization as much as we can. So in COVID time, it is important. Therefore, it's a lot of things in this slide, but what type of troponin we are talking about? Direct cardiomyocyte toxicity, or is microvascular, or is it pulmonary emboli, or is it stress cardiomyopathy, or is it the common garden variety type 1 MI, or it is profound hypoxia, ARDS, and troponin. So it is something that invites the multidisciplinary approach and take a big look at the patient. But having said that, I would say that STEMI is kind of easy, because once you recognize STEMI, the subsequent course of the care is kind of becomes obvious. You have to institute anticoagulation, you have to institute antiplatelets. There are lots of anticoagulation and there's lots of antiplatelets. You can do lots of permutation and combination, 256 different ways I can tell you, and sum up in a very simple way, 2 lines. No need to cry anymore. We have now plenty of evidence that if you give adequate anticoagulation with heparin or bivalirudin or any other heparin for that matter, and if you give early and powerful antiplatelet, then you achieve the purpose, and there is virtually no difference in the outcome if you can institute this therapy after confirmation of the diagnosis with proper adequate anticoagulation and antiplatelets to achieve the effect early on, and therefore you look for a sweet spot, because there is hazard. There are the early hazards of the therapy, because if you give too much anticoagulation, too much antiplatelets, there is a risk of bleeding. But if you don't give adequate, then you don't get the benefit of addressing the underlying ischemic events. With that, let me give you this question. A patient, 60-year-old, who is 60 minutes away from a hospital that can do primary PCI. He has paroxysmal atrial fibrillation, chest discomfort, and then suggestive of ischemic sounding chest pain. Metoprolol, apixaban is the direct oral anticoagulant, no more novel agent anymore, and atorvastatin digoxin. And I'll do it later. And this patient, the initial laboratory results you can see, but more importantly, this is the EKG. Any comment? Any participant? And we'll take any suggestion. So this is a patient who came from outside hospital and then paroxysmal AFib on this medication, apixaban, digoxin, metoprolol, and patient comes in now, looks like in sinus rhythm. And what is your comment? Anyone?
There is ST elevation in 2-3 AVF.
Correct. So there is
So
ST elevation
MI.
AVF, and then you can see that there is ST segment depression in V1, V2, right? And then lead 1 and AVL. I would request any of the faculty, whether with this EKG and this clinical presentation, do you want any more EKGs like right-sided lead, or do you want to have any comment? And our observation is that this is sinus rhythm with inferior ST elevation, and the EKG pattern and the clinical presentation is consistent with an acute inferior ST elevation MI. Is that a good working diagnosis, or you will consider other differential diagnosis?
There is comment, Hafiz Bhai, in the someone said, Norshin Tabassum said, I would like to see both right-sided and posterior ECGs, and Munir Khan said need to do right-side ECG, and Dr. Gibbon said right-side ECG is needed.
All these are good suggestions, and I say that the right-sided EKG, first of all, the emergency room physicians, I tell them that do not waste time by doing right-sided EKG before you call us, because time is important. And then the question is, the right-sided EKG and right-sided VR elevation is suggestive of RV infarct, and if there is an concurrent RV infarct, and hypotension, the mortality goes several folds actually. So this is therefore important to recognize that. But if there is no hypotension, many will argue that why wasting time? And another important thing, that if there is disproportionate ST segment depression, or V1, the R wave is dominant and the T wave is upright, there is concurrent posterior MI. So you think that there may be more than just RCA infarct, because this may be involving right ventricle and maybe part of the posterior wall of the left ventricle. So you may be in big trouble. But importantly, I would request you to not worry too much about the EKG, but look at the patient. Because if the patient is hypotensive or not, is the patient has any bradyarrhythmias or not, and is there any aortic regurgitation murmur in case there is an aortic dissection, and we are calling it just inferior stay elevation MI. Look at the chest X-ray, and if you have an opportunity to bedside echo, look at the aortic root and there is any pericardial effusion. But in all probability, if you take a good look at the history and this, it is likely that this is inferior ST elevation MI, uncomplicated. This is what I need to know from the fellow in the ER. That is it a real, meaning it is truly a STEMI, and the second, is it a complicated or uncomplicated? That means cardiogenic shock, pump failure, severe mitral regurgitation, pap muscle rupture or pap muscle dysfunction, or there is a VSD. All these are important issues to immediately recognize. And every time there is this chest pain and acute coronary syndrome, quote unquote, in the ER, make sure that 5 catastrophe is in your head. 1, ST elevation MI, 2, pulmonary embolism, 3, pneumothorax, then aortic dissection, and then esophageal rupture. Pneumothorax and esophageal rupture is very easy to discard, but then PE and then dissection, always remember. Anterior ST elevation MI with aortic dissection is rare. Almost you will be lucky to see it, because generally we don't see them because they die in the field. So inferior, you always pay attention. Very, very important point. And pulmonary embolism, we'll show you some cases, an example that has a typical pattern in the EKG. We need to recognize that and remember there is profound hypoxia, sinus tachycardia, and you may be lucky to see this. So we all know this.
Hafiz bhai, I'm going to interrupt you for a minute. Hafiz bhai,
Yeah.
There was a question in the chat box. I guess you have to explain to the junior doctors the reciprocal change, because someone commented it is inferior STEMI plus septal ischemia. So I guess you need to explain to them a little bit about the reciprocal.
Okay, so
change,
there are many theories about the reciprocal changes, but I tell you that when you read the EKGs, that if there is a 2 to 3 millimeter ST elevation in the inferior leads, and there is the transmural injury, then opposite the transmural injury, you see the reciprocal change. If that reciprocal change is same as 2 to 3 millimeter in the inferior, and it called this proportionate, then there is no further posterior MI. But if there is more, and then R wave is upright, T is upright, that raises question that there is, in addition to the reciprocal change, there is posterior extension of the inferior MI. Isolated posterior MI is extremely rare. That means you only see this ST depression, T upright in the V1 and then R dominant without inferior changes is very, very rare. And if you do the posterior lead, as you suggested, in that situation, you will see ST elevation in V7, 8, 9, 10. There is a report from San Francisco, UC San Francisco actually, that is it any more beneficial that if we do 16 lead or 20 lead EKG? And they found that only in rare situation that is helpful. Therefore, if you use the clinical conundrum that the patient is behaving like an MI and there is these changes and you are vigilant that it could be acute posterior, you will treat that as if it is ST elevation MI and not ST depression. Is that clear? Or any faculty want to say anything more? So we know that the patients present with this way, right? Unstable angina, non-ST elevation MI, and then ST elevation MI. We'll focus on the ST elevation part. This EKG and the series of EKGs I will show, I have put this as either STEMI or STEMI mimics. That means patient is 50-year-old coming with chest pain. Every patient is like that. Let's go through this exercise. This patient with this EKG, is it a STEMI or is it a STEMI differential, and begs the consideration that this may be something else? What do you think? Deepal, what do you think? Are you there? Or anyone jump in?
You can call it as acute STEMI because there is ST elevation in.
Yeah, of course, I totally agree. And the pattern is anterior, and then look at the lead 1 AVL. There is a lateral, anterolateral extension, right? How about this one? This is 50-year-old coming with chest pain. I'm not disclosing the whole story, but let's recognize this EKG first.
The T waves are tall in the anterior leads, namely the V2, 3.
But if you look at this lead 2, 3 AVF, and then look at the PR in the lead 2, PR depression, in AVR, PR elevation, and then the ST changes, the ST elevation is really concave upwards,
Yeah.
right? And then this is really global. If you look carefully, precordial leads, including V5, V6, lead 1, AVL, then lead 2, 3, AVF. So God is not that unkind that they give you STEMI in all 3 territories. So
Pericarditis.
this is pericarditis, absolutely. So when you keep your mind open, and the emergency room physicians or someone with this EKG may panic, but if you look carefully and then you talk to the patient and then find out patient was having fever or and on and off pain, and take the whole story. You can even listen, get a pericardial rub. You can look at the echo. Echo may be hyperdynamic LV. So that will help you. This one, the patient comes in with chest pain, and then they are saying, I'm worried this could be STEMI. So I don't know, Wadud is here. Wadud went through extensively teasing out this bundle branch block. Wadud, do you have any comment on this? That
in this ECG, if you look at lead 1, the QRS complex is whitish. That's also true in case of 5 and 6. But look at AVL. I don't know why it is like that. And the point is, if you want to have MI in a presence of left bundle branch block pattern ECG, you have to have Garbosa criteria fulfilled. And that's not being fulfilled here.
Yep.
So I have to think there is something else. It's an STEMI, a mimic, or something like that.
Right. Exactly. Totally agree. And if you can, those of you who are not familiar with Garbosa, and be aware of this spelling. In the gastro trial, they looked into this when they presented with left bundle. It is left bundle, it is new to the patient, new to you. But more importantly, it has to be new to the patient. Often we don't know that. And the chest pain syndrome, the shortness of breath, chest pain, the clinical presentation has to be consistent with STEMI picture. And then you can sell it as acute ST elevation MI. Just with the EKG, please don't go by that. This patient may have a cabbage in the past, cardiomyopathy and toe pain, or below umbilicus pain. I call above umbilicus, I will entertain with this abdominal pain, and inferior MI sometimes can present that, but below umbilicus, it is non-existent that any coronary event will be associated with that. And then the garbosa, the 5 millimeter and the discordant and concordant, and then ST elevations. Look at that. If you have all three, then the specificity goes higher. With one, the sensitivity is high, but the specificity is low. Now, this one, any comment? Tough one, huh?
Whenever you have this type of ECG, the key is the clinical scenario.
Yes.
How the patient is presenting.
It's absolutely brilliant comment that you always. So we are clinicians, and we are emotional to read EKGs because we are cardiologists, but also we are clinicians. We look at the patient, if what direction the patient is going. And also there is no harm in doing a repeat EKG, see whether this is evolving or not, right? So it is important. And then if you have the privilege of accessing a bedside ultrasound and you know how to interpret wall motion, you can see that. Transmural MI, which is the STEMI, you are likely to see some wall motion abnormality. But wall motion abnormality and making your decision for non-ST elevation MI with subendocardial ischemia, you may not be able to make a good decision. But if you get it, you get it. But if you don't get it, don't think that it does not exist. How about this one? This patient was 50-year-old, coming with chest pain, also have some lethargy.
This could be hyperkalemia.
Yes, absolutely brilliant. So if this patient is hyperkalemic, then we need to treat that first and figure out what is the underlying issue and make sure that you know how to treat hyperkalemia and sort this out. Because you take this patient to the cath lab, many interventionalists, including my senior fellows, say that let's go to the cath lab and have a look. Cath lab is not a photography lab. Cath lab is not a photography lab. You go there to do something, and you are going there with the safety issues. You take someone there, renal failure, hyperkalemia, you may end up in disaster. First thing we learn in medicine, do not do any harm. And because you did not recognize this, and because you were nervous, and because you could not make a proper decision, that patient may die on us, and we don't want that. This one is chest pain coming with this, and I told you earlier that look at the V1, V2, there is upright T wave, there is inferior ST elevation, there is lead 1 ABL ST depression. So this patient has infraposterior myocardial infarction. This patient has history of diabetes, hypertension, hyperlipidemia, coming with chest pain. And the emergency room physician says there is anterior ST elevation MI. And it depends on what EKG you are saying. Sometimes you see computerized EKG saying that there is a STEMI. So how you tackle that? Any comment?
This ST elevation is not typical of STEMI. There is no covering up. It just seems just like the J point elevation, which may be also present in case of early take-off variety.
Actually, this is LVH related, Dipal, and I have examples of J point. This is like LVH. Look at this. It fulfills whatever way you look at the Romil Estes criteria or Cornell criteria. This patient has typical voltage criteria for the LVH and LVH related changes. So you can tell the emergency room physician the clinical picture is not good. Patient has chest pain on and off for last 3 days, and this is LVH related, so they will probably accept that. And I want to tell you something about the lead V4. Some people get excited with the biphasic T wave in the presence of LVH. Be careful about putting too much emphasis on the so-called Wallen sign. I would go by clinical presentation in that situation, because that can be present, you know. This patient came in with chest pain, and the emergency room physician saying he's still having pain, he needs to go to the emergency cath lab. I already activated for a STEMI. You agree with the emergency room physician or you don't? He's so convinced that he gave aspirin and prasugrel or Brilinta, and then asking you to go to the cath lab. And then you are driving, and they send you the EKG.
No, this is tachycardia. This may be tachycardia-induced ST depression, and some
but there is no tachycardia really. And what do you think, Saidur or Nasser or anyone? Any other comments? But look at this. There's PVCs. You know, in medical school. Yeah, go ahead.
There are some ST depressions also in V2 and 3.
Yeah, but look at the ST depression in V2 and V3, and then R dominance in V2, and then look at the ST depression in lead V1. This is actually a true posterior. And this is very important. We don't teach students to read EKG by flipping through, but if you flip this is actually, you will see that there is ST elevation. In the emergency room, they teach this a lot, and the resident told me that this is ST elevation by flipping the EKG. I said, yeah, I agree, but that's not the way we teach, but be careful. And this patient came into Las Vegas, and then previous cabbage, and patient had some abdominal discomfort. Daughter, who does not see the dad for 5 years, got very worried and brought the patient to the emergency room. And they activated the cath lab for a STEMI. You concur or you don't?
I want to see the recent past ECGs, whether this is...
We don't have that. We don't have that, but actually this patient came from Pittsburgh, and the cardiologist there is my friend. I actually called him later. He sent me an old EKG. Look like the same. But we already knew that this, because the EKG pattern is interesting, that there is deep pathological Q waves and ST elevation, right? And if I tell you that this patient had similar EKG from about 6-9 months ago, what will be your diagnosis?
LV aneurysm.
Correct. Yeah, correct. So we don't need to worry about STEMI. And then this is a problematic situation, right? When there is the V-paced, ventricular paced rhythm, then you only go by the clinical. But I don't know anyone will make any comment. Emergency room physicians try to invoke Garbosa criteria in V-paced situation. And anyone has any comment on that? Do you like that? Or you buy that or you don't?
Actually, in these cases, troponin and echo, these two and the clinical history, these three things will make you the diagnosis.
Could not agree more. And as Wadud says, I just want to make one comment. Biseptal dyskinesia, you should not be fooled. you need an independent wall motion abnormality other than the septum. That will give you some clue, and the clinical presentation is even more important, right? With that in mind, let me show you this EKG.
This is classical Garbosa fulfilling.
Excellent. So you want to highlight that, Wadhu?
Look at the ECG. The QRS is whitish in lead 1, also AVL and 5-6. That means it's LBBB pattern. Yes. Now, with the LBBB, the ST segment should be down. The TUF should be inverted. Here, 1, AVL, 5-6, all are showing ST elevation. Disregard
more than 5.
Norm. So, this is the primary ST segment change, which occurs in ischemia. So, this is the case in a proper scenario. This is the case of Garbosa criteria fulfilling acute ST elevated MI. We cannot be sure which valve is involved, but you can rest assured this is ST elevated MI.
And then the other criteria also it fulfills. Look at the ST elevation, yes. B5, B6, lead 1 ABL, right? So it has at least 2 criteria here that fulfills the Garbosa. And importantly, LBB or RBB or LVH, Professor Chowdhury mentioned this secondary STT changes and primary. You need to recognize in LVH there is ST changes. It is symmetrical, asymmetrical, and is it primary or secondary? The more you look at these things, you will be able to recognize that whether there is associated ischemia or injury pattern. In this case, this is more like an injury pattern. This is a ST elevation MI. Left bundle and left axis can be a problematic, but some people will say this is more extensive conduction system abnormality. Again, the clinical is more important. Right bundle. Left bundle difficult to interpret, but right bundle is not a problem for interpreting the ST elevation MI. You'll have to invoke the same criteria for the right bundle as well. What about this one? This patient is on dialysis, came in with history of chest pain on dialysis, and this EKG. So this is hyperkalemia, sine wave. Look at the acidosis, coexistent and treat aggressively, right? And this is the Brugada pattern EKG. This is what I call the shoulder down type. And you have several types. This is not an EP conference, but be aware that Brugada can be a problem. And don't be ashamed. I have cath Brugada patient calling it a STEMI and coronaries are normal. And you need to recognize basically if you can. Now, this patient is a father of our ICU nurse, had craniotomy about 2 weeks ago and coming with chest pain, and then this EKG following an event in the emergency room. I will give you more story, but see whether you can comment on this EKG. Anyone? There is sinus tachycardia, right? Or
so we have 20 minutes left, sir.
Okay. So ST elevations in the myocardial leads, and then look at the ST segment elevation pattern, and then the patient had a code, PEA arrest, profound hypoxia, and then it was diagnosed as pulmonary embolism. ST segment elevation in pulmonary embolism is extremely rare, but it can be associated with hypoxia and ST elevation, and particularly shoulder down type ST elevation. And more common findings are sinus tachycardia And then in the precordial leads, V1, V4, because of the RV changes and RV ischemia, you can see T inversions. In the COVID time, it is very important to recognize. Other important differential of ST elevation is the Osborne wave and sinus bradycardia. So in summary, the ST elevation MI and ST mimics, this is from New England Journal of Medicine. This is a must-read paper that gives you all the differential of ST elevations and how to sort this out. So I will finish this last few minutes about focusing on the management, that it is important that we recognize this. There's in-hospital death is really high if we don't treat. And therefore we recognize this. We talked about how we recognize this ST elevation. If you have a system in place, then you actually save time with the first medical contact and the balloon time. If you have an ambulance system, the ambulance can transmit the EKG. EKG can be recognized. Patient can be evaluated, go to the cath lab, and mechanical revascularization with primary percutaneous coronary intervention, and the dot to balloon time keep less than 90 minutes or preferably 60 minutes if we can. In the absence of that, we give fibrinolysis. If we can give, we give primary PCI. We cannot give the primary PCI because of the distance issues, logistic issues. We can opt for pharmacoinvasive strategy. And look at this. If we do the revascularization, we significantly reduce mortality. And these are in-house mortalities. So it is very, very important that we achieve the reperfusion. And you need to be aware about the absolute and the relative contraindications for thrombolytics and how you institute the anticoagulation and antiplatelets, and then have a system in place. We have come a long way actually to institute this primary PCI, just balloon angioplasty. With balloon angioplasty, we actually caused more harm with platelet aggravation and then also further thrombus burden, and realized that acute vessel closure was high, and therefore we said, okay, we'll give glycoprotein 2B3A inhibitors and give the mechanical revascularization. It came down nicely. Vessel closure was less, but then there is this dissection and mechanical problem from the balloon angioplasty. Then we got the metallic mesh, we call the stent. There is actually prevention of that acute vessel closure, dissection treated well, and then no complications in the hospital. And we call this stop MI, but subsequently we had the further problem with the restenosis. Stent thrombosis is just thrombus formation with the stent. Can be acute, subacute, or late. But stent restenosis is all about smooth muscle cell proliferation, and aspirin clopidogrel doesn't work on those. And we still had this problem, and therefore we invented the drug-eluting stent, and that has reduced the stent restenosis rate to single digit, in some cases even less than 5 to 2%. In the case of STEMI, now in uncomplicated ST elevation MI, we are down to even less than 5% mortality. So no question that lytics versus PCI, the PCI works better. And if you can institute the dot to balloon time and revascularization early, you have a far less mortality. And this is the cartoon showing that the earlier the reperfusion, the better is the outcome. And if we, in the absence of that, as I mentioned, in areas like in Las Vegas, in Nevada, a large area, there is no cath lab, and we coordinate with thrombolytics and then ship the patient to the primary PCI hospital. In Bangladesh, that's ideal, that if you have remote areas, you can coordinate, you can make a network and system. We have excellent telecommunications. We can take a picture, send it by text, look at the EKG, coordinate the care, and then we can get the reperfusion very early on. This is an unfortunate patient where we had these ST elevations and then a lot of PVCs. The LAD was occluded. Patient was prepared well. The patient received antiplatelets, anticoagulation upstream, and then we were able to put a temporary wire and then revascularization, and all went well. But it all is a coordinated care. It is not just the cardiologist doing this. We need to prepare our frontline physicians, make them aware, recognize the ST elevation in mind, and then coordinate the care. This is a, maybe Mishu can, Chowdhury can make a comment. This is a LAD that we discovered that this is a bifurcating lesion, and then I just treated the LAD and balloon angioplasty the diagonal. Would you have done double stenting, Mishu?
No, not at all. In my setting, I don't like to.
Yes, and
just because the plaque shifting is more there rather than the stenosis, rather than the residues.
Chowdhury's comment, there's a paper now that says that it is better to use one stent if you can, and if you have particularly TIMI3 flow in the side branch, just leave it alone. And I call it LIA, leave it alone and follow up the patient and make sure that you have proper anticoagulation, antiplatelets. So TIMI3 flow is very important. Once you go to the war zone, make sure that not only you restore the flow in the artery, you have a good microvascular reperfusion as well. And we use adenosine and nicardipine, or you can use verapamil, and whatever way you can, so that you can get this. Some people use myocardial blast grade for that. This is just a cartoons. We did a work in Nevada, and this will be expected to see probably in Bangladesh. You are probably aware what it shows, that in a STEMI situations, if you do not give any therapy, look at that. If you don't give fibrinolytics, if you don't do PCI, you just give aspirin and heparin, that's not proper treatment. The mortality, in-hospital mortality, can be 4 or 5 times higher, which is really not acceptable. But when you institute the therapy, you can go down really significantly. This is all comers, including cardiogenic shock. But if you exclude the cardiogenic shock, and delayed presentation of STEMI can complicate with cardiogenic shock. If you exclude cardiogenic shock, the mortality can be even in the 2 to 3%. So pharmacoinvasive therapy does work if you do coordinate this care well. Then pharmacoinvasive versus primary PCI, almost neck and neck. And I don't want to go into that, but that tells you that we need to have a good coordination of care to address this issue of STEMI. This talk was not meant for addressing the complications, but just give you an outline about how to recognize ST elevation MI and how to institute the therapy. The principles of therapy is antiplatelet, anticoagulation, and then as fast as you can go with this either pharmacological reperfusion with subsequent coordination with PCI, or if you can achieve, like many centers in Dhaka, they are doing excellent in terms of instituting primary PCI. And I can tell you for sure that I looked at the data from National Heart Foundation. Their outcome data is very comparable with major institutions in the US. With that, I will stop and I'll take some questions. Anything on STEMI and STEMI care?
That was an excellent presentation, Hafiz Bhai. I would like to know from the faculty of Bangladesh, what is the overall situation of primary PCI in Bangladesh overall? I mean, I know it's very specific in certain centers in Dhaka, but even in Dhaka, are the government institutions, doing more primary PCI?
Actually, in my experience, the primary PCI in public sector is mostly office time. Off time primary PCI is very rare or occasional, but there are some private centers I know where near about 90 plus or 95% STEMI is dealt with primary PCI. The rest of the non-PCI, primary PCI may be due to lack of awareness by the patients or some contraindications to primary PCI. There are one or two centers I know in Dhaka city, but from public point of view, still we are on time.
So this was a very good point, and I don't know whether Azam is here or not. We
Yes.
are actually trying, and I talked to you as well, that there can be a system to develop a network, so that people know from outside Dhaka that they can, coordinate and go under that network, and we can together we can coordinate this and tell the patients where to go and what to do. I don't know. Azam is there?
Yes. Thank you, Abhi. Actually, before going to this question answer, I just want to know what about the latest situation of primary PCI in Las Vegas in COVID era.
Okay, so to cut it short, as you know that in the beginning we were worried about the PPE and the exposure of the healthcare professionals, and we ended up in more problem actually. That they give fibrinolytics and then ultimately go to the cath lab even in worse situation. So SCC, if you look at Itisham Mahmood from UCSD, revised this, and now we are going back to the usual path. Only thing that take precautions about PPE as if the patient may have COVID. But this actually raises the question. You should be able to recognize the true STEMI. So only patients you take is true STEMI, not like, you don't know, this patient is is not a true STEMI and I just did a cath. So if you can avoid, but in real situation it is, you may be burnt with Takasubu. We have a plethora of cases with Takasubu in the COVID era. Not sure why that is the case, but that's okay. And luckily in our hospital we have PAPR, and we are using PAPR also if we suspect. But I do simple things: chest X-ray, see the thing, whether there is any infiltrate or not. In uncomplicated cases, no hypoxia, and you can probably just use the KN95 or N95 fine. But if in a established case of COVID or high likely chance of COVID, or it is COVID, then we use PAPR.
We are the same way, Hafiz. In the beginning, we were very selective with, like you said, with the the temporary guidelines with the COVID. But then we found out we are running into more trouble because for a Takasubu or stress-induced cardiomyopathy, we did a similar thing. People end up getting thrombolytic, and then we found out actually it was not a true MI. So we are just cathing. If it's a real MI, everybody's getting cath now. Although the number of COVID has increased significantly in Iowa. Actually, 2 weeks ago, our hospital was at full capacity, but we never stopped doing primary PCI for STEMIs. Actually, there is a question from Dr. Mithun Kumar Mondol. Says primary PCI is not available for COVID STEMI patients in Bangladesh. Is there any contraindication? So I think Dr. Hafiz Chowdhury Ahsan Hafiz just answered that question. Actually, there is not a contraindication as long as you are well protected and your team is well protected.
Nasser, can I add one point?
Yeah, sure.
Yeah. Actually, there is no true contraindication in case of STMI. If you are confident enough it is true STMI, you should go for primary PCI if it situation permit. Last 40 years it is proven that ST elevation MI is the primary treatment, is the primary PCI. So you, as much as possible, you should advocate this primary PCI strategy. Thing is that what your center are capable or not, that is the main issue, number one. Number two, what situation you are dealing, that is the second issue. And what hospital regulation you have and what country regulation also is very, very important regarding this point. This is I think, the answer. But in our national guidelines and guidance, we prepared a national consensus document. We encouraged, as because for our resource constraint, we encourage to go for Lytics first. If it is then deteriorate, then you can consider by this time COVID test is available, then we go for this pharmacoinvasive strategy right now. And now we are thinking we should reopen our primary PCI strategy, and I think the next issue will be published recently, how to reopen our primary PCI protocol in NICVD, not national level. Then we should consider for the national level.
All right. Thank you, Ahsan. Hafiz bhai, there is another question. How to manage acute STEMI patient with coincidental intracerebral hemorrhage? And that's a tough one.
Okay, so first of all, if you have, it is very, very unlucky situation. But I would warn you one thing. If there is, how the patient presented, if it is a headache and then intracerebral hemorrhage, and then they did troponin and then EKG, and the troponin is positive, and the EKG shows ST segment changes, ST elevation, it may not be a type 1 STEMI, because sometimes we see that intracerebral hemorrhage and Takasubu state. So I would tell you to do an echo, and if you can do with the contrast echo and see whether there is any apical ballooning. So I tell you why I'm saying this, because we have a couple of cases, and one of my colleague in the night got this, and he said that they are pushing me. I said, first of all, you can't go and do anything, because without anticoagulation, antiplatelets, we know that we are helpless. And going to the cath lab just for photography is not going to help. It may jeopardize patients. Who knows the creatinine, hemodynamic instability. But this was on his nerves. And then I told him, you can do an echo. He said, there is nobody here to do an echo. I said, okay, then shoot the coronaries, but do an LV gram. You'll be surprised. First of all, he was excited that there was no coronaries. And then he did shoot the ventriculogram. It was Takasubu. So there is a clue, because if there is ST elevation, say precordial ST elevation, but Takasubu can present in many ways, ST elevation and ST depression both ways. The clue is that if you have a couple of troponins, and the troponins are mini troponin, because transmural MI, the troponins are usually 25, 50, 70, but if you have troponin like 2, 3, and then not budging too much, and at least you have two different troponins, that is an interesting clue to you. But I would say it is actually a negotiation with your intensivist, that don't panic. We'll have to live through this MI, whatever it is, because in the presence of intracranial hemorrhage, we are really helpless. But it is a rare occasion.
Yeah, Hafiz bhai. I'm asking you these things, that how far you are going for the primary PCI in your center, because like a patient with, you have told that already you have started treating these patients with confirmatory COVID positive patients. So in that case, the patient with all the symptoms of the COVID, like ground glass opacity is there, and along with X-rays showing bad, and hypoxia is there, high flow nasal cannula you have to use, and at that time also subsequently you have seen that that the coagulopathy is there also, obviously, and at the same time, and you have seen this elevation with the chest pain is there. So at that time, whether you will go for out of affection or out of the class 1 recommendation, whatever it is, you are going to touch that patient for primary PCI. You're doing that one now, or just you were leaving that one?
Okay, so we have so far full blown. It is a tough luck. One thing you need to say to yourself, why I'm on call tonight. But we have at least 3 cases, and I have published one of those cases in my book, the COVID-19 case-based approach. And Chowdhury, you will probably appreciate this, because you are an aggressive guy. We are basically compelled in these cases. just balloon does not work. We got to do thrombectomy. We use penumbra because these are all clot. And after the clot removal, sometimes one case
Hafiz bhai, first thing, you are touching these patients now or not?
Yes,
because
yes,
you are
yes.
planning to. You are touching these patients.
Yes, yes.
You're
Because
touching. So you have a dedicated cath lab, because I am as a cath lab director. I am also telling that. So the next day all the elective cases. So how you do that, those cases?
Okay, so
the next morning, like.
Okay, so out of our 3 cath labs, the cath lab that we do this patient, we do a terminal cleaning. After the terminal cleaning, it is actually ready to go by our ID.
We do the same thing in the beginning.
How much? Oh yeah, Nasser, how much impact actually with the terminal cleaning, the sort of terminal cleaning actually is helping to make the lab COVID free. So it's not pretty clear still now. So what sort of cleaning actually will help you to make the cath lab, that part of the cath lab is COVID free, and not only for us but for the next patient which is actually COVID negative and you have an elective PCI or something like that, and I am actually whether I am exposing that patients for another COVID thing, because I am wearing a PPE, so it doesn't matter for me that much, but for the patient.
Okay, so I don't know anybody will be able to say that it will be COVID free, but our ID says that you need to wait for 6 hours. It's arbitrary, I think, but we actually don't use the lab for that day. We just use other labs.
That's I'm telling.
After 24 hours, we use it again.
So that's why Hafiz bhai, in our country, especially in our private centers, not in the government centers, so we are 24 hours we are open, and 24 hours we can do the primary. So we did it before. So even at midnight, at 3 p.m. we are doing the primary PCIs also. But the thing is that now in these situations actually, how much it will be really possible. Other than the pharmacoinvasive therapy, because it is head to head, almost touching the both lines are almost touching each other graphically. Right. So in that case, whether I will jump for that one, though what you have told that I'm an aggressive one, but still I don't want to jump in that way actually for going to these sort of things, because I'm actually jeopardizing the other populations, the staffs who are not actually that much aware, even in your hospital also. I don't think
let me jump on that issue. Let me jump on that. Let me clarify even more that because there is a COVID, full-blown COVID and STEMI in 9 months of pandemic is not that common. Full-blown COVID and STEMI. This is not really, in our experience, at least I have not only my hospital's data, we do whole Las Vegas, and we do about close to 900 to 1,000 primary PCI. The overall COVID and full-blown COVID and STEMI is not that common. But my point is that in the fear of COVID, if you deny primary PCI to the non-COVID patient, then it is a disaster. And that's why ACC is very particular that triage the patient, recognize this well, and if it is not a full-blown COVID, then you go with the STEMI pathway as usual. And they are encouraging, because of this fear, that you fully prepare yourself with this PPE. It is a tough call, and I totally agree with you. You need to decide or make a strategy according to the available resources and how you can handle this. But I must tell you one thing, in Azam, in Dhaka city, it is actually very disheartening to see that off hours, the STEMI intervention, primary PCI is less. Is there anything we can do? And I think that probably one issue, but the bigger issue, Azam, you did not comment, is how we can develop a network of coordination of care, which I think we can all work together. I mentioned to Chowdhury and Deepal, and I also talked to Heart Foundation.
I think Hafiz bhai need to start from an EMS network, EMS type of We need to start some people with the EMS training.
But I just request all the faculty just think about this. We can go and do another discussion sometime. Any other question from the audience?
Bleeding ulcer after PCI, minimal duration of antiplatelet in this situation.
In Nasir, a question
Sorry.
chat box. How long we can continue dual antiplatelet therapy in recent days?
Oh, that is the question, exactly. Dr. Khorshid Mozumdar, bleeding ulcer after PCI, should be the minimal duration of antiplatelet therapy in this situation?
Khorshid Mozumdar, okay. I think,
you want to take that question?
Okay. Thank you very much.
We are running out of time. Please take the last question.
Bleeding after PCI, it is the major issue. Right now, you are seeing that high bleeding risk patient is a very hot topic for discussion. In case of most of the bleeding post-PCI situation are GI tract, around 62% cases, and excess bleeding around 6 to 9% case, and other peripheral and other cause 6 or 7% like that. Most important issue, when you're dealing the PCI cases, whether it is complex or true complex lesion or what are the type of the stent, it is also important. If you use very recent third generation stent like Onyx or like that, or suppose Giants or Synergy, you can continue DAPT 1 month at least, then you can discontinue at any antiplatelet as you wish, either ecosprin, aspirin or clopidogrel or ticagrelor, whatever you like. But the decision should be come from the primary cardiologist who actually dealing the patient, who is the preference of the patient's clinical subset and other clinical comorbid conditions, and what is the future risk of thrombotic events. But at least 1 month. If it is possible, after doing precise depth score, if it is more than 25, then you should continue at least 1 month. If it is less than 25, then you can continue for at least 3 months or more longer duration. After that, you can go for depth score. If it is more than 2, then you can continue more long. After 1 year, you can continue. If it is not, then you can discontinue according to your clinical demands. I think, Hafiz bhai, would you like to add anything more?
No, I think very well said. We wait for the endothelialization and then the worry about stent thrombosis, because you really want to make sure that you don't get this ischemic complication. The better we are doing with the stents platform, and then the better we are seeing the endothelialization, and then more antiplatelet effect that we are seeing. One day we may be able to cut it short. There is shortcut. And now, lately there is even claim for one agent, like a ticagrelor alone versus dual antiplatelet. But so short of society guidelines, I would agree that at least continue 1 year. And most people will agree that acute coronary syndrome, 1 year is kind of a standard practice. And then in certain situations, the interventionist will be able to tell you if it is a bifurcating lesion, crash technique, lot of metals, long lesions, left main, vein graft. They may want to prolong this further depending on the risk benefit in terms of prevention of ischemia versus bleeding. And I think I will stop there.
No, I think I agree with Azam and Hafiz bhai. The data with the third generation stents are so good that we can stop even in those situations. The patient is bleeding, we can even stop after a month, and we are just not using bare metal stents anymore, just because the data is so good. The instant thrombosis rate is so small. I think we are running out of time. If the faculty has anything to add, otherwise we'll, I guess, wrap it up today. And I really thank you.
I want to raise a problem which I frequently encountered in my invasive life, that we are getting more and more very late stent thrombosis. So stopping the DAPT after 1 year sometimes may be very difficult. And in the scenario of resistance to antiplatelets like clopidogrel, even aspirin is a real problem also. So this could not be so easy task for us to
And very well said, Dipal, and particularly, with the clopidogrel resistance is higher in Bangladesh.
So, sometimes if it's a healthy young patients, I think there is some data that actually there is benefit of continuing the dual antiplatelet therapy beyond a year. So I think here mostly what we do is we do a joint shared decision, sit down with the patient and say, if it's a healthy young patient, 55-year-old had an MI a year ago, we would sit down with him and said, there is benefit of you continuing the dual antiplatelet beyond a year, but there is some small bleeding risk, and most of them will want to stay on dual platelet, so we will leave them on dual antiplatelet for longer.
Nasir, for last 20 years working in this dual antiplatelet or antiplatelet therapy, talking about that one and working with that one, it's like walking in the maze, Still now there is no concrete data there, because when you're telling the Onyx 1 trial, they're telling that in HBR cases you can go for 1 month DAPT. So if Onyx is that much potent that after 1 month there will be no problem, then in normal patients, why I will give more than 1 month?
No,
So
absolutely.
the mechanism is the same there, so the why I will do that one. So that's the thing. But the thing is that, of course, what we need now, that the durable, the polymers or the stent materials, whatever it is, we are very much hopeful about the the bioresorbable things, but that it went in vain. But yet we are hoping that one. So this sort of things, until it is coming, that very late stent thrombosis, whatever it is, it's a progressive disease. So you have nothing to do actually, but you can't. You have to weigh in between the risk and the benefit, and you will go on with that way, patient to patient. Sometimes you will have to think in a different way.
It reminds me of 2003. We did the drug-eluting stents, and in the 3 months was good enough, arbitrary for endothelialization. Then we realize it is not. So sometimes we are so much evidence-based, but sometimes we take arbitrary decisions. But I think individualization is important, and we'll have to wait for more data.
Hafiz bhai.
We have only 2 minutes actually, then we are going to get disconnected. But go ahead, Azam.
I just only 1 minute. Actually, how long you should continue, it depends on your primary cardiologist. He should decide. He should assess the risk-benefit ratio. If he considered it should be continue more, as you know, 1% late stent thrombosis is still present in this era. So, if you see the depth score is more than 2, then you can easily continue your antiplatelet therapy long enough than 24 months enough. So, I think it is one of the issue, and at least if very high bleeding risk patient, then at least if possible, you can continue 3 months. If it is not possible, very high risk, then you can continue at least if it is third generation stent, thinner stent, then you can continue at least 1 month. Then you can consider accordingly your clinical scenario.
And I would ask the participants to listen to Dr. Valentine Fuster's commentary, similar as Azam said.
Now I can request Professor Wadud sir, he can make, I think, is the expert in the high bleeding risk patient, he can make a comment.
And Wadud, you can draw the conclusion of this program, because we'll be running out of time. Wadud is
there. And thank you, the organizers, for organizing such a beautiful interactive session. What I want to for the youngsters, that you should remember the ECG patterns and always pay attention to the clinical scenario, then interpret. Don't be overzealous. Take a little bit of time to assess which way you should go, then decide. And yes, primary PCI is good. And yes, it's very difficult in this country. And yes, in this COVID situation, when we do not have the luxury of having dedicated cath lab, it's very difficult to do that. But we can still go for pharmacoinvasive therapy with very good result, as Saidur Rahman was saying. So I hope the discussion, the interactive sessions will be very helpful for everyone. Thank you, sir.
Thank you. It was an excellent discussion. Thank you, everybody, for participating. Thank you, our honored guests, and thank you, Hafiz Bhai. Thank you, all the participants.